thank you, Hugh and Cirdan, for the invitation to give this talk to you this morning, updating our progress and others' progress in the arena of algorithm development for digital pathology. So first of all, I have no conflicts of interest to declare. Always hoping, but nothing yet, I'm afraid. The Digital Pathology Centre of Excellence in Coventry kicked off a year or so ago now in some hype generated by University of Warwick. This is a partnership between ourselves, GE, Omnics and Warwick University. And one of our first pieces of work really was this, which I spoke about at last year's meeting and is now published in Histopathology. This is our validation study, comparing digital pathology to glass slides and seeing how badly we did with it, and the answer was just as bad as with normal slides, really. So we made exactly the same number of mistakes. Sometimes we made the same mistakes. And just for those of you not familiar, this is Gartner's hype cycle. I was introduced to this when I was a trainee by a surgeon giving a talk on laparoscopic surgery. And of course, surgeons have got the attention span of minutes, so the time at the bottom is in days for surgery, slightly longer for pathology. But essentially, you get the enthusiasm. Everyone wants the equipment. They want to have a go with it, and they want to try what their favourite thing with it and see how it works. And most of the time, it doesn't work very well. So you get this sort of trough of disillusionment developing before people really establish what things are useful for and start to use them properly. And I think, as Richard pointed out, I think possibly more than once, digital pathology pathology generally takes a long time. So digital pathology goes back to the mid-60s, in fact, when people first started putting together images and computers to analyse them. But really, it's not been until relatively recently that we've had scanners that are capable of dealing with whole slide imaging on a scale that's required for routine diagnostic work. Our lab in Coventry produces 1,000 slides a day, and just getting through that scanning time is a significant hurdle, and only now really have we got the equipment that can do that. So we're now able to use whole slide imaging for routine diagnosis, which opens up really the arena for image analysis. This is a slide I got from Nazia Rajput, one of my collaborators in the Digital Pathology Centre of Excellence in Coventry. It comes from the BBC. I have no idea how accurate this is, but clearly somebody thinks that the market for digital pathology is going to be seriously big before much longer. Let's take you back, and this you'll be familiar with this from Richard's slides. So this is how we are, or how we were. This actually is a little bit older than 2012, to be fair, but we are pretty much the same. We get a request, the question, and at the bottom we provide the answer in the form of the report. And this bit in the middle is what happens in the lab, and I think it does bear some repetition. I was at a meeting just before I came away here from our academic clinical fellows. These are our bright young things across the hospital who have been fast-tracked through their training program, so they're doing academic work alongside their routine training. And we'd just given our presentation on work we're doing on small cell lung cancer, and one of them asked, well, what does histopathology do? So this is what we do. We take the sample, we process it to wax, we cut sections and look at it under the microscope. And of course, in this setting, the pathologist, the poor old pathologist here, is working completely unaided. All he's got is his microscope, his slides, what's inside his head, and what he can get from the textbooks, and that's what gives you the answer. And even when you've shelled out for one of these, which in our case cost us $1.5 million, you know further on. Okay, you're still looking at the image yourself, and you're making sense of it. And really what we want to do, and what our program is all about, really is developing computer-assisted diagnostic, i.e. tools and algorithms which improve pathologists, make them better at what they do. So that's really what our centre's really geared with doing. And I'm going to talk about the activity really that's going on in these areas, which we see as the main application areas for digital pathology. There's immunohistochemistry, IHC, biomarker assessment, which is already is actually the only part of digital pathology is in routine practice at the moment, really. And then there are tools which quantify, grade disease states. Most of these are relevant to cancer, but there's also a group of inflammatory diseases where these sort of tools are required. They're quite wide-ranging and will be quite useful once they get them working. And then there are tools which assist pathologists by finding things that are not common, rare events, small areas of the slide, and lots of slides you're looking at. So we'll talk about this in prostate template biopsy and sentinel lymph nodes. And then there's the arena of automation, where you can take stuff away from the pathologist altogether and get the computer to do it. So that's really what this talk is going to be about. But before we get on to the talk, I've been practicing, Peter, for tomorrow's fish off. And here we are. This was last year, actually, on the River Lochie in Scotland, and this is what's called the Falls Pool. I don't know if you know much about salmon fishing, but the height of the water is critical. This is at 1'10", really good height for the Falls Pool. The fish will be running, and we're in with a chance this morning. So, but I put this picture in really because I want to draw attention to the fact that it's an analogy really to pathology. We work, algorithms are going to be working both upstream of the pathologist and downstream of the pathologist. The pathologist is going to be the key player, as usual, in the middle, but these things are working either side of him. And actually, where these algorithms work makes a difference to how they're going to work and the strategy we're going to employ them. So, for example, the upstream algorithms, the stuff which is done before the pathologist looks to, really involves taking data straight from scanners, outputting onto servers, and looking through masses of data on whole slide images to find events of interest to then flag up for the pathologist to look at when he gets a slide to look at. So this will be off the workstation, on the cloud, computing. Anything which you require the pathologist to initiate, i.e. find the tumour and then ask what grade it is, has to work either at the pathologist where he's working or downstream of him. So if it's a case of cancer grading, it's a tool which has to be on the workstation, operating at the time the pathologist says, there's a cancer, what grade is it? If you're talking about biomarker analysis, then you're talking about stuff which is downstream of the diagnosis. So pathologist has made a diagnosis of cancer and he wants to know, is it estrogen receptor positive? Those slides have to be cut and stained and then analysed downstream of the pathologist. So these algorithms may not be on the workstation, they may be on the cloud, providing you can manufacture a way that the computer knows where the cancer is and what it's got to look at to do the analysis. Or it may be on the workstation and the pathologist looks at it again and uses it, which is a conventional way of doing it. It's some basics which are worth pointing out, and this is to do with a lot of what Richard said really about how the computer looks at things and how the human eye looks at things are very different. The computer likes to have things standardized. It likes to have the color the same intensity time and time again so it can make the same measurements. So whenever you're doing algorithm development, it's very important to build in right at the start a system that standardizes the stain that you're looking at and you're analyzing. And we do this by separating out the various aspects of the stain. In this case, it's a H&E stain. So what we've done here is we've taken one section, that's its H&E stain. We've bleached it. Then we stained it with hematoxylin and scanned it, and then we stained it and bleached it again, and then stained it with eosin and scanned the same tissue, same section, stained 3 times over. And so you've got this ground truth of colour separation for the stain that you're using. And then for the intensity of stain, you go through this fairly complicated mathematical process, which I don't really understand, but essentially you take the colour out, you get to the grayscale image, and this is what you want to see, this is what you've been given, and so you do the maths to work out how you get these pixels to match those, and you end up with a false coloured image at the end, which looks at the same intensity to the target right at the start of the process. And this is known as stain normalization or deconvolution. And it's a very important piece of work to do right at the start of your algorithm development. So important, in fact, that one of the first things we did was make these tools available on the web as part of our stain normalization toolbox. So what we use in Coventry and Warwick is available on this website in order to assist other teams that are at work in this arena, should they wish to make use of it. Okay, so immunohistochemistry. This is commercial. This is a slide from GE, and this is immunocytochemistry for the HER2 stain, HER2 new test. This is a test for use in breast cancer, and this is a membranous stain. You'll be familiar now from Richard's pictures, but these are blue nuclei in the middle. You've got the brown stain around the edge. Positive staining for HER2 means continuous staining around the edge of the nuclei. Now, this is obviously a piece of breast cancer which has been stained. The pathologist has then looked at it and he's selected this area to score. And all the algorithm does then is produce the result for that area. So that's a tool that's used at the workstation by the pathologist, looking at the stain, selecting the area and running the algorithm. And that's available. It's in the market now, and it's being used by many groups. We ran a competition recently on HER2 staining. This is a Path Society meeting this summer, a HER2 contest, and we had 18 teams enter for this contest to compete with their staining. We had ground truth provided by Ian Ellis in Nottingham, and we had a man versus computer test to see any pathologists who wanted to have a go at the Congress. They came up and had a go, and they compared their results to the computer. The computer won in that contest. Warwick came. We were mid-table, I think, in this result, our team. But it shows the interest in this area from this group. So these really are the biomarkers at the moment which we'd be interested in developing these algorithms for. We talked about HER2, estrogen receptor, and progesterone receptor. They come as a triplicate really of biomarkers, all related to breast cancer. HER2 crops up again in other cancers. Most commonly we use it also in gastric carcinoma, but there are other tumours now coming on stream with which HER2 is useful. And it's important because these can be treated. These represent targets which can be attacked and treated, and the patients have a much better outcome as a result. PD-L1, program death ligand 1, is another marker which is emerging, or has emerged really, in lung cancer and emerging in other sites as well. The problem with this is that there are loads of antibodies. They all stain in a different way and require different analysis. So that's still quite a problem case to deal with. Ki-67 is a marker of cell division and rapidly dividing cells, and this is used in multiple tumour sites, and is quite a reliable immunostain we use a lot in the lab, and it would be very useful to have a general tool which did nuclear positive staining for that, so we could get more accurate readings of Ki-67 index in these tumours. So those are all what we're looking at right now, and this list will obviously extend as new markers come on with targeted therapies for the future. And most of them look at the moment like they're going to be dependent on immunohistochemistry as the main visualization steps. So they're all applicable to this area of algorithm development. Okay, so I'm going to move on and talk a little bit about disease quantification and grading tools. And start off with the Nottingham Prognostic Breast Cancer Index. So I trained in Nottingham some years ago now, but at the time Chris Elston and Ian Ellis had just published their work on grading of breast cancers and predicting recurrence and reduced disease-free interval and reduced overall survival based purely on the tumour grade. And it wasn't laughed at, but it was received with quite a bit of scepticism. Pathologists said that you really couldn't reliably grade tumours. It was a matter of opinion. And so but the Nottingham Prognostic Index broke down the grading into these three very measurable objective features that if you told pathologists about them, and then they went away and did it. They didn't do it very well. But if you told them about it and then you trained them how to do it properly, then you got somewhere. You got some consistency. And this is now completely embedded in breast oncology treatment the world over now. This grading system. So we've taken these elements of this grading system and looked at each individual area really to produce a tumour grading tool which can be used. And this is quite a nice study we did last year by two medical students doing their clinical attachment with us. And they took a load of bladder cancers, transitional cell carcinomas of the bladder, and they looked at mitotic index and they looked at nuclear diameter. And they got a very good split between correlating with disease progression and non-progression based on the cell diameter of the cells that they measured. This is some work that's been done on the mitotic counting algorithm. We've looked at some of these mitotic figures earlier in Richard's talk, but they come in different shapes and sizes, and obviously you need to count all of these to get your mitotic counting rate accurate. So this was the AMIDA Challenge contest. This was conducted in 2013. This I think attracted 14 groups. And the winners are up here. So IDESEA, DTU and Warwick were the top 3 placed teams in this global challenge, which was presented at MICI 2013 on mitotic counting. And this was followed by mitosis and nuclear atypia a year later. Again, similar number of teams took part in that group. And the interesting thing about this contest was that it received slides from different scanners. And it was only the Warwick algorithm which performed well on both those scanned images. The other teams had largely worked on one scanner or the other, and their results were not immediately translatable between the scanners. So I think that rams home the message about standardization of stains before you start your algorithm building as a key area. And then we moved on really and looked at tubal formation as another fact, the third really component of tumour grading. And this is work done by Korsak on his random polygons model for tubal formation. And this was followed by a challenge in Munich, MICI contest in 2015 at Munich, where I provided the ground truth for these cases. So we gave them colon cancer cases, moderately differentiated or poorly differentiated colon cancer cases. We gave them ground truth images which had been drawn around the glands, and then the test was run live in the hall in Munich during the contest. They had 2 hours to complete the test, and the results were, from some groups, were really very, very good. So really quite accurate delineations of the glandular formation in these tumours. So they're segmenting these malignant, very disordered glandular proliferations really quite accurately in this contest. And more recently, things have really, and in fact, a lot of the teams in that MICI challenge had used deep learning. But deep learning is a very common and widely used technique for training the algorithm to recognize patterns and motifs from multiple images supplied to it during the ground truth stage. And this was work which we did on colon cancer again. These are Duke's B colon tumours, i.e. they've invaded into the wall but they've not metastasized outside the bowel. And this is a big problem group really of patients. The patients that, in fact, there was an article in the paper the other day about prostate cancer, which reflects the same sort of dilemma. You know the patient's got cancer. What you really want to know is the cancer going to spread, and do we need to do something about it, or can we just watch it and treat the patient conservatively? Duke's B colon cancers fall into that group. These are patients who've had the tumour resected. We know it's invaded into the wall. We know there's no lymph node metastasis or widespread metastasis, but has the patient been cured by that operation, or not, and if not, they may well benefit from chemotherapy. So having an idea that you can assess at the time of the resection that this patient is a high risk for developing metastasis, is in that group that will come back, you can then move on and treat more aggressively with chemotherapy. And Dukes B, a lot of colon cancers are Dukes B. It's one of the commonest stages of the tumour to be resected, which is good in a way because it means that a lot of these patients are salvageable. They will be cured by the surgery. But we recognise that as pathologists, we recognise that we can see some tumours such as this one here, where there's clearly invasion of the tumour into the adipose tissue in a very spiky and aggressive way, and we would call it an infiltrative margin. Whereas tumours which do this, they have a big lump of tumour and they gradually push through. We would call them a pushing margin. And by and large, there is some association between that two. Infiltrating tumours do tend to do worse than pushing tumours. The problem is, where do you draw the line between whether a tumour is infiltrating, as this one is here, or pushing, as the same tumour is doing here? And really, this is somewhere where we think the computer algorithm has a role to play in analysing the degree and the pattern of that infiltration. In these coloured images, the false coloured images, the tumour cells are in red and the non-tumour cells are in the other colours. The blue cells represent macrophages and the yellow cells the lymphocytes. So you can get an assessment of the amount of lymphocytic infiltration that's going on in the tumour, and that again is likely to be important in how the patient is doing. That will reflect the way in which the body is already attacking the tumour and the success of that process. So those are things which we think will be useful. In this study, what has come out as quite a strong indicator for progression has been the way that the fibroblastic cells are associated with the tumour islands. So we've identified some motifs, high diversity of these fibroblastic cells related to the tumour, which has a significant association with metastasis later on. And likewise, the aberrance, the degree of aberrance from an ellipse that the predominant tubule formation is showing is also coding for metastasis in this group of patients, as summarised in this table here. So this is still early work on these cases, but we think we're making some progress in whole slide imaging and deep learning in providing some tools which will help with predicting for metastasis in the future. Rare event detection is the next thing I wanted to talk about, and this is a real problem. Okay, this is when you're running a health service. Obviously, you want your pathology lab to be providing the right answers. It's quite important, and you're at the moment giving them bigger and bigger challenges. Believe me, day in and day out. And one of them is prostate core biopsies. So, prostate template core biopsies. This is a procedure you do for patients who've got a bit of a raised prostate marker. But you're not seriously worried about them. You don't really think they've got cancer, but you've got to do something. And to do something is a systematic biopsy of the prostate along a grid pattern, which is a template. That's why it's called template biopsies. And usually these generate 20 to 40 cores per case, per patient. Okay. Each of those cores you're going to look at on 3 different levels of slides. So you are talking about hundreds of slides per case, per single case that you get with these things. And when you're into that level of tissue examination, fatigue starts to creep in at the pathologist level. All right, you have a real problem in maintaining quality of what becomes a very laborious and boring process of looking for rare events in lots of slides. And this is big data. Okay, so we're generating 45, 75 gigabytes per case in this instance. So this is a lot of data, and this is where you want your upstream algorithm running. Okay, you want to export all of these images onto a server, and you want a server to be grinding through them and finding the cancer, which it can then present to pathologists for verification and sign out. And that will alleviate a lot of the tedium and the boredom at this level. And it's interesting, at the US CAP meeting this year, we were talking about digital pathology. This was one of the few areas which we explained to a team of experts who were highly skeptical about digital pathology as a route forward. But when we explained that actually you can give it 40 cores of prostate and it'll come back with the one that's got cancer in it, or they did get interested. And you could see them thinking this through, that this was actually going to be really quite a useful thing. Same thing goes with sentinel lymph nodes. These are lymph nodes which are marked with dye or radio markers, so you inject it that where the tumour is, and the node that it drains to you can see or detect with a Geiger counter. You take that out, that's your sentinel node. If that's involved, patients obviously got nodal spread and warrants more surgery, with usually a block dissection of that lymph node group and so on. So quite serious surgery, a lot of repercussions, a lot of prognostic outcome, but an improved outcome for the patient. So it's quite important to know. But these again are slide heavy. You're talking about 30 to 60 slides per case, immunohistochemistry as well as H&E. And here's the algorithm running. This is one of our group's algorithms finding metastatic breast cancer in a lymph node from a case of breast. Actually, it's quite a big lump of tumour, and most pathologists find that fairly easily. But what you're aiming to do is find the tiny bits that are right out in the peripheral node quite often. So that's rare event detection and automation. So can we remove the pathologists altogether from this labour-intensive work? So this is a piece of work done by Siobhan Quemby. She's an obstetrician that we work with down our way, and her team's identified natural killer cells, which are subpopulation of lymphocytes, as an indicator of recurrent miscarriages. And patients who have frequent miscarriages sometimes seem to have more natural killer cells in the endometrial stroma than the normal patients would. I don't quite understand what the relationship is between these natural killer cells, but you can imagine what the public thought when they get hold of it, natural killer cells and recurrent miscarriages and so on. But anyway, I think probably it relates more to maturity of the endometrium than anything else. And this can be influenced quite well by glucocorticoids. So if you know the NK cell is raised, you can improve the chances of the pregnancy surviving by glucocorticoid treatment. And we do this by staining with a marker, an immunohistochemical marker, CD56. And the interesting thing about this assay that we did is that as pathologists, we weren't involved in this at all. We provided some technicians to do the staining, and that was it. Cut the sections and stain them, and the algorithm did the rest. So it counted up these NK cells, worked out which ones were away from the epithelium, because that's the most important bit. If they're in this part of the stroma, that's the really strong indicator. And provided a count back to Siobhan's group, who then went on to treat or not treat the patients, as the case may be. And that's proved a very successful strategy for some of these patients. So that is an automated in-house algorithm that's running. And she still hasn't paid us for it, incidentally. And here's another one which we've tried to get off the ground with varying degrees of success. This is breast cancer core biopsy. So this goes back to right at the start of the talk, where I was talking about HER2, and this is similar stains as estrogen receptor and progesterone receptor in breast cancer. And as I indicated, that commercial algorithm required the pathologist to identify the tumour and score it. So what we tried to do was to get the pathologist to make the diagnosis, that's what they do, and mark the bit of tumour in the core, and then to have the section stained and read by the computer independent of the pathologist. So everything that's downstream of that was done by the computer. No pathologists involved. They just made the diagnosis and told them where the cancer was. And this involved obviously an overlay step, a series of segmentation overlay steps where you get the immunostain overlaid alongside a H&E, so you know which bit of the core you're looking at, you know where the tumour is, etc. And then you can run the algorithm and produce the score. And actually the results were quite encouraging. So this is the algorithm scores down here, pathologist scores up here. We're scoring all the negative ones and all the positive ones, and most of the ones in between we're getting somewhere close to the line. So it's quite encouraging that this could be done, and we could do this. This sort of proof of principle does work. And so I'll talk a little bit more about that in a minute. But the other areas which we think are amenable to automation are cases which produce a lot of normal, and this is took me a long time to fall down to this one. But obviously, normal is normal. It's as you would expect it to be. You can build an algorithm to look at the parameters of normality with very tight restrictions and pick out what is normal with a very high degree of consistency. And if it does that and tells you that everything else is abnormal, at least you've got rid of the normal stuff and you don't have to look at that. And that's particularly appropriate for colon biopsies. I don't know if we've got any gastroenterologists in the room today, but they produce a lot of biopsies with nothing in them. And if you don't have to look at them, that's a great saving in pathologist's time. Duodenal biopsy is another one where lots of biopsies are done for queries, celiac disease, etc., and they're all normal. And of course, vasectomies and fallopian tubes, which is not a huge piece of work, but nevertheless it exists, and we don't need to do it. But there's a catch, and this is the catch really. So all of these algorithms, they work very well in the lab, you can set all sorts of academic parameters to measure how effective they are and so on. But when you put them into practice, usually lots of things go wrong. And one of the first things which goes wrong is the quality of the scanned image that you're dealing with right at the start. Now, pathologists will put up with a lot, believe it or not. They don't make a lot of fuss. So here we have this is a H&E section on the right, and this is a grayscale image on the left. And you can't see this very clearly, but there's a scratch on the cover slip of this slide over here. And you can see it much better on this image, which is actually what we call a blur report, and it's telling you that this is an entropy-based analysis of the focus quality of the section. It's telling you these parts of the section are out of focus, and there's a scratch on the cover slip, and that is why they're out of focus. All right, that's interfered with the scanner's ability to focus on the tissue plane, and when you look at that area on H&E, at first glance it's difficult to pick up because it's mostly fat, so there's not much there. But the bottom half of this picture is perfectly in focus. And there's a line across the middle, and above that it's not quite in focus. It's good enough. You can see what's going on. There's nothing seriously wrong with it. It's just adipose tissue, but it's not in focus. The problem is if you're asking an algorithm to do anything on that, it can't do it, and it will fail the slide. And when we've run routine cases through our algorithms, this has been a recurring problem, that the quality of the scan is often not good enough to run the algorithm. So we need to improve that. And all of these scanners have this problem. They don't have good quality control over the focus plane in particular. So improving that is an important aspect for the future. So I'll finish with that and just introduce you to my team. These are pathologists here. This is Ian Cree, Professor of Pathology, and Yiwa, who's currently on maternity leave. She's just had a baby boy. And she did, and I did all the ground truth work for the colon. Ian did a lot of the travelling for that. David Epstein is a mathematician, fellow Royal Society, and Hesham is another pathologist at Adam Brooks, helped with some of the ground truth. And these are our programmers and algorithm writers in NASA's lab down here. So thank you very much.